From Robert Wood Johnson University Hospital, this is Medically Necessary.
Welcome to Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff. I'm Chris Hoenig, joined as always by Dr. Jim Salwitz. Dr. Salwitz, another beautiful day in the medical neighborhood.
Absolutely, Chris. Nice to see you. And I heard you got your second vaccine.
I did. A little bit achy, about 12, 16 hours afterwards, but a little Tylenol and bounced back up. And it really is, I had a little bit of a moment. I'm not going to lie.
Yeah. No, I can really appreciate that. So also congratulations. That's all good indeed. So, we move forward.
Yes, and speaking of vaccines, finding out now the date that the FDA will consider the Johnson & Johnson vaccine. That's February 26th, so about 2.5 weeks from now. And I think we can all agree that can't get to the market soon enough.
No, I think that's going to be a game changer, just because of the massive volume of the single shot vaccine. And it's proven efficacy. I mean, that's what people have been looking for. It would hopefully help dissolve many of the lines and back up around this country, and we get to a safe sort of or a society that much faster.
Yeah, 66% efficacy overall, 72% efficacy in the United States, but the most important part there, 100% efficacy against hospitalization and death, and 100 million doses expected to be delivered to the United States by June. So that's just huge for getting a lot of the general population vaccinated.
It really gets us there.
And, when we talk about the general population and the prevalence of the disease in the general population, one way we've almost been able to kind of get some insight into how much disease is there out there is through pregnant women, the women who come into our hospital to deliver their babies. Every one of those women gets tested, and we see how many of those come back positive, whether they're symptomatic, asymptomatic. So with that, I'd like to welcome in our first guest this week, Dr. Justin Brandt from the OBGYN division at Rutgers Robert Wood Johnson Medical School. Dr. Brandt, thank you so much for joining us.
Hi, Chris. Thank you for having me.
2 weeks ago, the World Health Organization kind of had this wavering on vaccine recommendations for pregnant women. First coming out saying, we recommend they don't get vaccinated, and then coming back and saying, well, there's really no evidence that it's harmful. What are you telling your patients when they come to you and ask about getting vaccinated?
It was a busy week after the WHO made that recommendation and then changed their recommendation largely in response to the sort of public outcry. But a lot of patients are confused and a lot of patients don't know what to do. And this certainly complicated the picture. We don't have evidence about the safety of the COVID vaccine in pregnancy because pregnant women were largely excluded from the COVID trials, the Moderna and the Pfizer vaccine trials. And so because we don't have the safety data, there's uncertainty about the risks. But what I am telling patients, we talk a lot about the mechanism behind the vaccine and its theoretical safety profile. It does not contain live virus. It contains no adjuvants that are intended to enhance efficacy. And it stimulates an immune response that is good for the baby. These maternal antibodies are crossing the placenta and likely conferring some advantage and some immunity to babies when they're exposed to this vaccine in utero. The other thing we talk about with our patients is this vaccine doesn't go into the nucleus of the cell where the DNA is kept. There's no reason to think that this viral mRNA platform is going to interrupt or interfere with DNA for mom or for baby. So lots of reasons why there's a theoretical safety profile that's reassuring for our patients and their unborn babies.
That's, obviously very reassuring, but, for our patients, but it's still, I guess, there's still that level of anxiety, after these kind of conversations, what kind of decisions are you seeing people make?
So patients are choosing to do the vaccine. Now, some are struggling a little bit more with the decision. So I take this opportunity with all my patients to provide more information. So first of all, we have to consider the prevalence of the disease in our community. During a pandemic, your exposure risk is real just by going out of your home. We talk a lot about several other factors. So number one, pregnancy is a risk factor for more severe disease. We know that pregnant women with COVID, compared to non-pregnant women with COVID, are at higher risk for getting hospitalized, requiring ICU admission, intubation, ECMO, and death. So pregnancy by itself is a high-risk condition per the CDC and is certainly a risk factor for more severe disease. So we definitely talk about that. We also
and
want
we've seen that here, Justin, unfortunately. We
Sure.
have seen this here at Robert Wood, unfortunately, with a number of women, families that have come in sick, and it's been tough. It's been some pretty hard times.
Yeah, we've seen certainly some bad outcomes, and it is absolutely possible that vaccination may have prevented those. So we're thankful that it's out there. But we also want patients to consider their risk of exposure. Our healthcare providers on the front line are at risk, and we have advantages working in the hospital system because we, especially on labor and delivery, we're testing our patients. We have access to PPE, but being a healthcare provider puts you on the front line, and that it definitely increases your risk of exposure. And then we also want patients to think about their individual risk profiles. So pregnancy is a risk factor, as I mentioned, but lots of my patients, because I'm a maternal-fetal medicine doctor, a lot of my patients have complex medical disease. They have obesity, diabetes, hypertension, lots of medical problems that are also risk factors for more severe COVID. So when you put this whole picture together, you have an effective vaccine, a vaccine that has a reassuring safety profile during a pandemic, and pregnancy is a risk factor for more severe disease. So with all of this together, a lot of our patients are making the decision to vaccinate. And I support that. My division here at Rutgers supports that. And a lot of the professional societies also are supporting vaccination for patients who are prioritized for vaccination based on the risk factors. Society for Maternal-Fetal Medicine talks a lot about shared decision-making, which means we talk about the risks and the benefits with our patients, and we encourage them to make the decision that's best for them, but they have to make that decision, and we are highly supportive of that decision.
It's interesting. It also complements the conversation we had this podcast a couple weeks ago about the concern of young women, particularly about getting the vaccine and whether it might affect fertility itself. And the observation was made that, perhaps the real risk is not the vaccine for fertility. In fact, it's not. But the real risk, is the infection and fertility, and therefore the possible injury that one can get, long-term injury from the infection, both to men and women, from the disease. So what your recommendations is complements, those observations that were made.
If patients are considering a pregnancy, there's no evidence that the vaccine increases the risk of infertility, and it's actually, now's the time to get it. Get it before your pregnancy, and hopefully there will be some advantages for you during your pregnancy, and that those patients won't go on to develop COVID and have severe disease.
Now, you mentioned that the antibodies crossing the placenta and transferring some of that level of immunity to the baby. When we've had these pregnant women that come in and test positive to deliver their children, we don't see COVID itself. Just because the mother is positive, the children don't end up testing positive, correct?
Right. Most of the patients who have COVID, their offspring don't have the infection. In fact, because we don't think there's a strong risk of transmission from mom through the placenta to baby, when babies are found to be positive with COVID, often it was not in utero transmission, but rather a neonatal transmission that occurred after the baby was born from being exposed to family members who have the infection. I can't speak enough, though, about the antibodies. Natural immunity, patients who've received who've gotten the infection, we know that they go on to generate an immune response, and those antibodies have been tested in cord blood and in baby serum, and those antibodies are present at higher levels than we expected. And this data just came out of, I believe, JAMA Peds a couple weeks back that really showed that the babies exposed to moms with COVID have more than expected, I think, antibodies that may be protective for those babies, especially before vaccination occurs. And it speaks a lot to the potential benefit of the vaccine because the vaccine promotes that immune response in moms. And many of those antibodies are IgG, which can cross the placenta and confer some protection and immunity for those babies.
And this complements a long-term concept, critical concept of maternal-fetal medicine, of the maternal antibody immune protection of the infant in those first critical 6 months or so of life. when we can't vaccinate. I mean, that's such a critical time, and you're basically giving this. What you're saying is really fascinating, because you're talking about giving an added protection to a child that you're bringing into the world in the middle of a pandemic. So when you get to the question, well, can grandma come and visit the child? Well, maybe just a little bit. This is another feeling of safety, which is not to say that we should stop social distancing, masking, etc. But it's to say that this is just another way that you can protect your child, just like being vaccinated for the slew of things then that we try to be ready for. This is a way of preparing, your child for life.
Right. And there are precedents in pregnancy. We administer the whooping cough vaccine, the Tdap, at 27 weeks to our pregnant patients, with the hope that their maternal immune response will protect mom, but also will protect the baby during that first year of life, before vaccinations occur. So we have a lot of data about Tdap in pregnancy because we've been using it in pregnancy. And I hope, there's a paradigm shift in research related to pregnancy and these types of interventions. Historically, we've protected our pregnant patients from research. We have not included them in research trials to protect them from side effects and experimental therapies. But the paradigm is shifting to include some pregnant women in research trials, so that we're not protecting women from research, but rather we're protecting women through research. And that's where the future's going. And SMFM and ACOG have advocated strongly to include pregnant women in research trials. And I'm hopeful that this pandemic and this issue will highlight the importance of protecting our pregnant patients through research.
That's fascinating, because it complements societal observation in medicine, that research has been done on white males, and complements the system move towards inclusion of all people. And this is such a large group of people, 50%. Maybe 51% of the population, that we're, not that we have a desperate need to do adequate research and involve people earlier, and obviously the needed safety, but also we've moved so far beyond the thalidomide era in our understanding of biology and people and how to do research safely and how to protect people that, on the other hand, when we don't do it now, when we find ourselves in these situations of, and inadequately understanding how to protect and treat large populations.
Absolutely. When I was a med student, I remember thinking going into med school, when we're pregnant, our patients should not be using medications. You just don't do it when you're pregnant. And it turns out, the medical experience would prove that's not the right approach to medications. What guides our use of medicines in pregnancy is a discussion about risks and benefits. When the benefits outweigh the risks, that favors intervention, and that favors treatment, and that results in a healthier pregnancy most of the time. So in the discussion about the COVID vaccine, we do have some unknown risks, right? We don't have the actual safety data for pregnant women with regards to the COVID vaccines, but the theoretical safety and all of the benefits that we've talked about likely outweigh those unknown risks.
Right. And I think our deep understanding now of the biology of the maternal-fetal relationship and immune system, gives us a tremendous step up. And again, is another example of how in the last year we've been able to move so quickly to move the science so far, because of what we understand and what we're capable of doing. So it's exciting, and that we're able to offer this to women and babies, at this time.
Yeah, some of my patients have asked me if in the development of the vaccines, in order to expedite the process, the scientists and the researchers skipped important steps. And I've been able to tell them with reassurance, that no, just because this was fast doesn't mean that any of the normal steps were skipped, and that we, because of the way this vaccine platform works, it's easier to develop, and it's more scalable, and it has advantages that allowed for us to mass produce a safe and effective vaccine. So it's a remarkable time to be practicing medicine, a scary time, but for our patients and for docs, but it's been a remarkable experience.
Well, Justin, thank you so much for this very interesting discussion and this critical information. Obviously, people really need to hear it and understand. Both our colleagues who need to be explaining this clearly, and obviously our patients in the community. So really appreciate the hard work, and stay safe.
Thank you. You too.
Dr. Justin Brandt from Rutgers RWJMS Medical School. Thank you so much for the time.
You're welcome.
Coming up, we'll continue our conversation about vaccines. As a matter of fact, every day it seems there are more sites getting stood up to be able to get your vaccines. Emily Halu and Indu Lew, the two women leading the vaccination effort for RWJBH Health, join us next. We'll be right back.
As part of RWJBarnabas Health, Robert Wood Johnson University Hospital has a nationally ranked heart transplant program, is at the forefront of innovation in heart surgery and research, and has nationally recognized cardiac programs for excellence in transcatheter valve replacement and minimally invasive surgery. So get your heart checked, because your heart doesn't beat just for you. Robert Wood Johnson University Hospital. Let's be healthy together.
Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff.
Welcome back to Medically Necessary. Chris Hoenig here with Dr. Jim Salwitz. And, Dr. Salwitz, I was talking with Dr. Susan Borokoff, our chief of infectious disease and hospital epidemiologist recently, and she described getting the vaccine as being a liberating experience for her. And, I had my second dose last week, which, forget about body aches. I had enough of that from shoveling. Who cares about the second vaccine side effects, right? But what was it like for you getting the vaccine mentally? Was it really, did it feel liberating?
Liberating, probably. I think I would go further. I would say it was almost a catharsis. It's a trigger moment in time. I felt like, for half a second, like crying. There's just been, it's such a critical moment. And I think less so, actually, Chris, when I think about I felt safer, I think it less than this is such an unbelievably important moment in this battle. I mean, this is where we've been struggling for a year to get to. And this is the proverbial light at the end of the tunnel. We're not done. We have a lot of work to do. But, for me, it was that moment of, wow, this is an incredible inflection point. So, yeah, it was important, and I didn't even feel the needle. So I'm not sure that's because I was, in shock, of emotionally, or the needle was just so small. But, yeah, it's an incredible moment. And I have seen, I've seen people cry. I've seen people cheer. I have not seen people go out and give everybody smoochies yet. I think we're smarter than that. But it's an incredibly important moment. Thank you. It's a good insight, Chris. I appreciate it.
And I think that is one of the important points there. There is still a long way to go. Just because you get vaccinated doesn't mean we're going to concerts tomorrow. It doesn't mean we're having large gatherings again. There is still a way to go, but this is a hugely important step in this battle. And it is a very difficult and complicated step to pull off. And with that, I'd like to welcome in our guests for this part of our podcast. Indu Lew, she's the Chief Pharmacy Officer for RWJBarnabas Health, and Emily Halu, the Vice President of High Reliability for RWJBarnabas Health. Ladies, you are the ones behind all of this work in getting the vaccines out across the system, not just in our hospitals, but all these additional sites, the mega sites, the satellite sites. A huge undertaking that you've been working on here now for the last couple months.
Yes, Chris, that's correct. It was in the beginning when we're starting off, you're really starting with a blank piece of paper, trying to figure out logistically how to make this work. We know right now we have two vaccines that we're dealing with. They're both mRNA vaccines. It's the Pfizer vaccine and the Moderna vaccine, a little bit of different storage and stability. So that's brought into the mix. And then we know also that it's not only getting the first dose, it's getting the second dose and making sure people are adherent in order to get the full effectiveness of the vaccine. So a lot of logistical components to bring into the mix to finally see the shot getting into the arms of people.
Indu and I started in the end of October, I believe, and every day it was realizing or learning or hearing from someone else or reading one more thing that we had to consider for just getting whether it was getting the vaccine on site, storing it, inventorying it, documenting it, the regulatory pieces, and then the logistical and operational pieces of the clinic. So there was a lot up front that we just didn't know, and it was every day learning something more that we had to figure out how to put in place before the end of December.
How much of this was coordination with the state and with the federal government? How much is this internal?
really, in the beginning, it was a lot of conversations with the state. It starts simply as ensuring that each of our facilities were set up as a provider. That in and of itself, to set each facility up as a provider, ensuring that we had the IT components in place. Because what's interesting is that within 24 hours of a recipient getting the vaccine, that information needs to be uploaded to the state, that administration piece. So, so technically there's a lot of IT components that have to be put there. So a lot of conversations in the beginning on, with the state on ensuring that we were set up as providers. Then the second component is making sure that we had the infrastructure for storage and inventory within the pharmacy departments. It was really hard in the beginning to get an ultra cold chain freezer. It's not your typical freezer. So that was difficult. And then really mobilizing each of our facilities so we were operating in a standardized way. So there are thousands and thousands of people involved in the vaccination process, going from our clinic managers, the pharmacy, the IT, the registration people, the legal, the volunteers, all of these people. There's probably over 3,000 people involved in this process, ensuring that people can get vaccinated.
Wow, that's you think of it as a needle in the arm, as you say, but the upside, the downside, the following it, the tracking, and then cycling back these people for their second shot, which adds a whole nother level of connection, of complexity. So you can really start to understand the difficulty in just moving this forward.
Don't forget the system that we use to even just get the people into the clinic was built from scratch. So the actual app that we use, we had to understand what were going to be all of the elements that people would have to do before they got there, the screening elements, the appointmenting process, just had to be built from scratch by a large team internally to even just get people into the clinics. And that's worked beautifully. They've done a great job and really made our process possible via the app that was built internally.
The other thing too that I think is real important to understand, early on in the process, while we were building the IT components and the app and the registration, almost daily we were finding out different clinical information. So every time we got clinical information coming through, so the ACEP would come out with a separate recommendation, the CDC would come out with a separate recommendation. We had to pivot immediately because those screening questions, the IT piece was already built. So we had to find these pieces of information that was new, be able to amend the process that we had, educate everyone that this is the new clinical screening process, and then implement it all within a day or two. So the process was constantly changing, very fluid, and really proud of everybody on the team that was able to really step up and make sure that we were doing the right thing.
It's interesting. Chris and I have had many conversations, both on this podcast and off, about how this entire event brings us together even more as a system. And when you tell stories like this, the complexity of bringing all these people together to make this happen in real time. Forget, historically, a vaccine would take years to roll out. This is why. The incredible complexity. So, it's very exciting to hear not only that what you're doing now about the vaccine, but all these people you're bringing together, building together this culture of caring for ourselves and for the community. It's a remarkable event. You're changing history in real time.
And Dr. Salwitz, they come together, they prioritize this. So people left their normal jobs and day jobs and became vaccine full-time to make this happen in clinical informatics and IT and obviously logistics operations. Your clinical, clinic leads and managers who do this now full-time as a priority to get this into the community and the staff.
It's brilliant. And I think we have to be very sure that we show our appreciation for all these people and their work as we go forward, because, we do have a habit of, finishing up a crisis and then moving on and not, making sure that people know that these people save lives or are building something remarkable. It's truly a tremendous event. And you are given great credit but so is the system and what it is capable of doing.
And of course, mentioning that, this started out with employees and staff, and it has now moved on to the public. First of all, how many sites are we vaccinating at, and how many shots per day? Obviously, we're limited based on the supply that we get in, but how many vaccines per day are we able to put into people's arms?
Wow. So we have many different sites. We have our 11 acute care facilities that we're vaccinating at. We have the mega center in Edison. So now we're up to 12. We also have partnerships with counties. We have two partnerships in Essex County. We have Ocean County. We have Monmouth County. So now we're up to 16 different sites. So combined, if we're looking at what we're doing in all of those facilities, probably per day, you're easily upwards of 3,500, 4,000 shots potentially a day. Right in our acute care facilities alone, we're able to give over 1,700 shots a day. So it's a huge, huge undertaking. We are growing also, but again, the rate limiting step that not only we're facing, but other health systems are facing as well, is the supply of vaccine. That truly is our rate limiting step right now.
And hopefully,
will the Johnson & Johnson vaccine change that?
That's exactly where I was going.
Absolutely, because you have a third player on the market now. So now you'll have Pfizer, Moderna, and Johnson & Johnson. And with any of these manufacturers, they've already started the process of manufacturing. They're just waiting for the EUA approval. So that will push another vaccine onto the market, and then it'll increase the supply because the demand for the vaccine is overwhelmingly outpacing our supply.
And having said that, and I accept that there are more people now who want the vaccine than we're able to supply, and we're spinning up. But having said that, we actually still have a lot of individuals, even within our system, people that are giving care, that are hesitant about getting the vaccines. I mean, I know I'm not speaking in this case about physicians who I think have, on our research, has shown over 99% desire to get the vaccine. But I think other nurses, of the general staff in hospitals have some hesitancy. What's your thinking about that, and how we address that?
I absolutely think that vaccine hesitancy is a real issue that we have to deal with. I think the important piece here is education and building that level of trust. We need to educate the people that the FDA is not sacrificing safety for speed. These vaccines have gone through the clinical trials. They are safe, they are effective, and they're important to protect not only yourself, but the patients, your loved ones. I think it's an important message, and I think that's an education component that we have to continue.
And I would propose that that's maybe part of the job of the medical staff itself.
Yes.
I mean, we can't wait for the Johnson & Johnson to say it. I think we have to be saying it.
No, we have to, we believe this message. So if we believe this message, we need to ensure that we can educate our teammates, educate the public. That is our job as healthcare practitioners.
Even just an element of being proud of being vaccinated. I think there's some part of it that says, well, it's my own health, it's my own health decision, and I don't have to wear it on my sleeve or my shirt that says that I got vaccinated. But there is an element of that says the more people I see around me that are willing to share they got vaccinated, gosh, I really trust that physician when he's caring for my patients, then perhaps he's making that kind of decision. I can either discuss with somebody or I can at least have the visibility. And that's why those silly little stickers that say, that I'm a big shot, like it's doing more than just being proud of getting vaccinated. It's telling others that it's safe and that you believe in it.
The other piece too is that last year in 2020, we went through an incredibly difficult time. We saw things that we've never seen before. And we want to make sure that our part in ending the pandemic is ensuring that as many people as we can get vaccinated. I think that's an important piece. We need to end this pandemic, and this really is the beginning steps to doing so.
I think the work you people are doing is absolutely remarkable. The level of complexity in a short time frame is truly astonishing, and we owe you a great deal of thanks, and obviously a lot of work still to be done. But if we follow this path, we will recover, and it's an exciting opportunity, and we'll leave 2020 well behind.
And obviously for our clinicians that are interested in getting involved and doing more, if you read your newsletter to our medical staff here at Robert Wood Johnson, the link is there to be able to provide your information to volunteer in our local clinic. If you are interested in volunteering at one of the mega sites, how can clinicians get involved in that?
So as of right now, the mega site that we are sort of very intimately involved in and is very large is the Edison Expo Center site. And they will have an opportunity for medical staff to volunteer as vaccinators or even observers. And the process is still being determined as to how they are going to physically be able to volunteer there. But so more to come, and I'll definitely provide that for you and the medical staff. Internally as well, the medical staff is welcome to volunteer both at New Brunswick and at any of our other 10 hospitals that are providing vaccines. I will tell you from personal experience, being a vaccinator, it is hopeful and inspiring to see the good stuff going into somebody's arm that intimately is a really great experience.
Well, thank both of you for the hard work, and obviously for taking the time to talk to us this morning. It means a lot, and to us, to the system, and to the people of New Jersey. And we go forward together. Keep up the great work.
Thank you for the opportunity today.
Thank you.
Have a wonderful day.
Indu Lew, Chief Pharmacy Officer for RWJBarnabas Health. Emily Halu, Vice President of High Reliability for RWJBH. Thank you so much for your time. As always, you can subscribe to Medically Necessary on all your favorite podcast platforms. We're available on Apple Podcasts, Google Podcasts, Spotify. We have that playlist on YouTube. And of course, you can always find us on the RWJUH Medical Staff Portal. For Dr. Jim Salwitz,
Chris Hoenig,
thank you for listening.
Medically Necessary, brought to you by the Robert Wood Johnson University Hospital Foundation.